Oh, here it is. I'm sorry, it's a different one. I'm sorry. I'm sorry, I didn't see it, okay. Okay. This will be an outline today. We'll talk about just chronic pelvic pain in general. There's some slides in here on dysmenorrhea. I'm going to skip through those because I know you have an adolescent gynecology lecture, and but they're additional and I can send those to you. We'll talk most about women because chronic pelvic pain is a bigger issue in women than men. Then we'll talk about specific issues that occur in men and have time for discussion afterwards. What do women want? They want us to take the complaint seriously. Men do too, but chronic pelvic pain can be a little bit more of a common issue in women than it is in men. And it's also very elusive. I mean, there's a lot of times I just have to tell people, I'm not sure what's going on, but one, I believe you, and secondly, we'll certainly look into this. And this is when we call in the consultations, especially pelvic floor physical therapists, who I think are very important people to get to know in practice. New patient appointments may take a long time. I'm going to show you a history and physical form you can freely download, which really can save a lot of times. By definition, pelvic pain is the presence of pain for over 6 months. Now, we all love definitions. If somebody has persistent pelvic pain for 5 months, I think that's close enough for a cigar to start the evaluation in that patient. Adhesions are blamed for everything known to mankind, but rarely do adhesions really cause pelvic pain. I think that's just an excuse in a lot of situations because taking down adhesions usually doesn't help very much. And there's several chronic pelvic pain disorders which are associated with other chronic disorders. TMJ, for instance, irritable bowel syndrome, et cetera, and certainly migraine, headache, and things like fibromyalgia. One thing you want to be careful in both men and women is ask about sexual abuse or sexual assault in the past. It's been estimated about 40 to 50% of women who have a chronic pain disorder do have a history of sexual assault. It may be also emotional abuse as well. So a very key question to ask in the evaluation. Well, all pain is in the brain. We might say it hurts in my shoulder, it hurts in my pelvis, etc. Today it hurts in my Achilles tendon. So that's why I'm sitting today. So please accept my apology for that. But pain occurs in the brain. So again, if we have an injury here peripherally, it'll go down the dorsal root to the anterior root to the brain where pain is perceived, and then there'll be signals sent back to the arm or wherever it is to retract the arm away from that painful stimuli. There is upregulation of the pain sensors in the brain. There's actually biochemical changes in those who have chronic pain disorders of any type. We often like to talk about multiple pain generators. Rarely do we see a pain disorder sitting there by itself, and very common we'll see 2 or 3 different pain generators in men and women in the pelvis. They also may be associated with other chronic pains such as fibromyalgia, as we talked about just a moment. A couple of definitions I'd like to go over that you'll hear a lot of is allodynia, and that's a pain evoked by a stimulus below the normal painful stimuli. That may be like touching the back of my palm and say, oh, that hurts, instead of pinching it, which might be painful. Dysesthesia is an unpleasant, abnormal sensation. Common thing in women is insertional intercourse that might be painful. That would be an example of dysesthesia. Hyperesthesia or hyperalgesia is an exaggerated response to a normal painful stimulus. And neuropathic pain is a pain that becomes chronic after the acute injury. Again, there's been a change in the CNS settings and the neurobiochemistry in those people who have chronic pain. We'll often see psychological comorbidity, and we certainly saw that major depressive disorder tends to make pain perception worse. But I think it's, we have to be very careful that it's a little bit more than treating major depression. And there are certain antidepressants I'm sure you're aware of, and we'll talk about later. It might be better for those with major depression who have chronic pelvic pain. Stimuli can be from the point of origin. It can be referred pain. Certainly one thing we see as gynecologists is when somebody has a laparoscopy, they say, my shoulder hurts. Well, that's subdiaphragmatic pain, and of course C345 keeps the diaphragm alive and also generates or perceives the pain in the shoulder. There's trigger point pain and certainly central pain as well. This is a great free download, and this is for pelvic pain, specific in women, but it can be used in men as well too. I checked this reference last week, and it's still good, but it's from the International Pelvic Pain Society. There's sections for men, women, and both in this, and this is about a 10-page questionnaire we send out to all our patients with chronic pelvic pain and ask them to bring it in, or if they just come in and say they have chronic pelvic pain, we ask them to fill it out and fax it back to us. It has a pain questionnaire on it and lots of figures, and it actually does a very nice review of the 6 systems that we're concerned about in dealing with chronic pelvic pain. This is an example of this, and you can see the female body in the front and back and the vulva. They're asked to color in these areas, and I'm always amazed how you can diagnose fibromyalgia from this illustration. Sometimes they'll have every trigger point on their front and back illustrated. There's a visual analog scale and also lots of good information on this. On the physical examination of the female, and the male will go to at the end of the lecture, these are the points we'd like to take a look at. And besides the normal examination, we want to do a single-digit examination. 2-finger examination can be uncomfortable to many people. And so when we're trying to assess the pelvic floor and whether or not there's cervical motion tenderness or at least parametrial tenderness next to the cervix, 1 finger is certainly better than 2 fingers. It takes some getting used to doing this very slow, gentle examination. You also want to look at the gait as well too, because again, especially in our older patients, much pain is referred from the hip or the knee and from an abnormal gait, and they may perceive that as pain. Fibromyalgia is certainly another good thing to look at. This is another nice documentation of exam, and some of those who have insertional intercourse pain will actually do a Q-tip and see exactly where it hurts, and there's an entry dyspareunia that is usually used due to muscle tightness. It's actually non-surgical, and we have a pelvic floor physical therapy assess those patients. This is a neat little test. This is Carnett sign, and this sort of helps us determine whether something is myofascial, the abdominal wall, or is it possible visceral pain. And you had the patient do a leg lift, or this young man here is doing a head lift there, I guess. And you can see the physician next to him just doing pinpoint tenderness. Now, I think the interesting thing is, I don't know about where you live, but most of my patients cannot do a leg lift. And so I think the head lift works a little bit better for some of them. And if the pain is increased, that may suggest this abdominal wall pain. If it gets a little bit better, it might be visceral pain. But I think most of us can tell surgical pain from those who just have the chronic pelvic pain. Laboratory, not terribly useful. Of course, a CBC is always a good idea. You might pick up an elevated white count. A SED rate or CRP may or may not be useful. Usually it's not terribly useful, so nonspecific. Urinalysis and urine culture might be useful from time to time. In selected patients, gonorrhea and chlamydia cultures are a good idea. I certainly don't recommend routine culturing, and I had a consult recently from the wife of one of the county judges in Randall County in Texas, and she had had a hysterectomy, been married for 40 years, and wanted to know why she had a gonorrhea chlamydia culture, and not by me, but and I said, that's a good question. I don't know why. But I think some people do get insulted by that, and I think we have to be careful. I mean, when you've had a hysterectomy, the chance of getting gonorrhea of the vagina is almost 0. So other places you might want to test for it if there's some concerns. Pap smear per guidelines, and every other test suggested by the history and physical. Imaging, probably for women, ultrasound, especially transvaginal ultrasound, is the imaging modality of choice. You might see something like this, which is, I'm going to push the wrong button, sorry about that. This is a typical endometrioma, this ground glass, very Catholic appearance on this mass. That's easy to say that's an endometrioma. MRI can be helpful if you think there's adenomyosis, which is endometriosis in the wall of the uterus. And CT sometimes might help with radicular pain or spinal pain. And generally most people have had a CT scan, and that has some limited availability or limited use when looking at gynecologic pain. So, but radiologists love to do abdominal as well as pelvic ultrasounds. We try to stop them from doing that. That is expensive. They charge for 2 examinations rather than 1. And in most pelvic disorders, abdominal ultrasound is, quite frankly, a waste of money. So you just don't have the nice views that you have with transvaginal ultrasound. Well, when do you refer for laparoscopy for chronic pelvic pain in women? And there's some controversy about that, and I think there's way too much laparoscopy done for chronic pelvic pain. I think gynecologists are more than happy to do this, and if it's normal, they tell them there's nothing wrong with them. That should be a crime to tell people that there's no gynecologic pathology, but yet there may be other pathology, and to kick them out of the practice, I think, is inappropriate. From a primary care viewpoint, it's quite reasonable to try non-steroidal anti-inflammatory drugs. If they have major depressive disorder, treat something like duloxetine or Cymbalta, or some drug, antidepressant also has neuromodulatory effects. The reality is that laparoscopy is often normal, and when it's normal, you got to look for other pain generators. And one thing I like to tell patients is it's not endometriosis, it's not an ovarian mass, but there are other things that cause pelvic pain, and we need to figure out what it is at that point. It's also reasonable in those who are not trying to get pregnant to treat them with birth control pills and non-steroidal anti-inflammatory drugs for 3 months. The problem with all treatments for endometriosis is they all stop you from getting pregnant for a while. Boy, we'd love to have a drug that doesn't do that. But if they're not trying to get pregnant, we might see significant improvement in pelvic pain with birth control pills and non-steroidals of choice. And there's a lot of biology of what estrogen and progesterone do to pain perception, and both of those hormones tend to diminish pain sensitivity at the CNS. Other invasive procedures, you see my little hammer and a nail here, and that reminds me to say, if the only thing you have is a hammer, everything looks like a nail. Well, if you send these people to GI docs, what are they going to do? They're going to stick a tube in everything. It's a waste of money in most times, and they'll do it every single time. I don't mean that in a bad part, but if they have GI bleeding or they have bloody diarrhea, you damn right. I hope they get a colonoscopy. I mean, that's appropriate. But colonoscopy is not appropriate for chronic pelvic pain and those who have a negative test for bleeding, especially in younger patients who are much less likely to have a malignancy. What will the urologists do? Well, they'll cysto them, whether they have hematuria or not. Again, it is reasonable for microhematuria to rule out something called interstitial cystitis that we'll talk about in a little bit. But most women do not need cysto or colonoscopy in terms of workup. Here is sort of a six-system workup to think about. We're going to go through these step by step here. One is, of course, neurological, psychological, urological, the old bladder's down there, and I remember in anatomy, just everything seems to converge in the pelvis sometime. There's muscles down there, and muscle tension is a big cause of a co-generator of pain, certainly a reproductive organ in the GI system. So there's a lot going on here. In the reproductive system, you can think about dense pelvic adhesions, but unless the ovaries are just plastered, rarely does adhesions cause pelvic pain. And for the gentleman here, if you've ever been kicked in the groin, that's what it feels like to have a stuck ovary. It's not very pleasant when you have intercourse, but they have to be plastered. I mean, they have to have no mobility, and during the active intercourse, it's uncomfortable for the patient. Large pelvic masses can, certainly endometriosis can. The ones in salmon or orange, I'm colorblind, I don't know what color that is, are the more common ones, but you can see those listed here. Here are some of the neurologic things you want to think about. Certainly think about inguinal hernias from time to time. We do pick up quite a few hernias, abdominal wall hernias, especially those that have had prior surgery. Sometimes CT can be helpful for that in picking up these small hernias. Every once you'll find somebody has acute intermittent porphyria, but if they have a scar, especially a cesarean section scar, there's also a possibility they have cesarean section scar endometriosis, particularly if their pain tends to be around their periods and say my scar hurts. Some people actually say my scar gets bigger during my period, and that is a good suggestion that there might be scar endometriosis. Interstitial cystitis and kidney stones are big ones there, but there are other causes, including chronic urethritis that we'll talk about a little bit later. GI issues, irritable bowel syndrome is huge. In fact, about 70% of people with endometriosis also meet the Rome 4 criteria for irritable bowel syndrome. So again, we're going to talk about these things flying together. So it's not just treating endometriosis, it's not just treating irritable bowel syndrome, it's treating all these pain generators. And I'll tell you, if they have those two, they often have pelvic floor pain or pelvic floor tension myalgia as well. And here's the pelvic floor